All right, I'll stop you guys so we can get some reactions just briefly in the last few minutes here. So, can I have someone on this side of the room give us a little bit of what you talked about in your group around immediate reactions and informed consent thoughts? Yeah, so I guess I wonder what the general feeling in the room is around harm reduction here. What is the greater harm? So would this patient have greater benefit from accessing estradiol than she would from being refused estradiol? And what about the formulation of her choice? Would anyone feel inclined to turn her down? Yeah. So we certainly can talk with our patients about risks and benefits of medication, as we do with any medicine, keeping their own health history in mind. And, it's tricky. Sometimes we feel nervous, but just because we see a risk for a patient doesn't mean that they are not prepared to accept that risk. And we may spend more time talking about formulations of estradiol and risks of different formulations, but ultimately, this patient may perceive that injectable estradiol is what she wants to do, understanding the potential risks, and we can proceed with that.
I'm curious, if this were a cisgender woman with hot flashes in this scenario asking for estrogen, I would say no, right? And so I'm curious about any data on dosing for women who are older, who want, like Martha, who want to start.
Yeah, I'm not aware of particular guidelines. I don't necessarily think there should be particular guidelines in this event. There's certainly a range of dosing that's recommended for injectable estrogen in general. But if Marta were to start, the lowest possible dose of estradiol valerate, would it meet her goals for her gender affirmation? And if not, are we doing harm? Yeah, and I think the point about, HRT for cis women is well placed. We can't always compare these things to each other. Sometimes the WHI study gets brought up and tries to get it applied to trans women, and that's probably not appropriate or relevant to this population. But a lot of the perception of risk that we have around hormone prescribing comes from studies of cis people. And we have sort of developing data that includes the actual population of interest here. But, some applies and some may not apply, and some of the risks that we associate with HRT for cis women may be more acceptable in the context of gender-affirming hormone therapy, because without it, someone is going to do worse. Any concerns about mental health history as a contraindication to hormone therapy for this patient?
Yes.
Tell me more.
We discussed the idea of it, that it's a really fine line to walk, because of course we don't come from medical backgrounds, but more from breast care. And so you walk the fine line of not wanting to push a person into seeking something that may not have worked for them in the past. Maybe they've gone to counseling and therapy and that hasn't been good for them. So taking more of an advocacy approach to talk about, here are some pillars of things that we think could be supportive to you on your journey as you start this, maybe a better approach versus saying, hey, we need to address your mental health first before you start hormone replacement therapy.
Yeah, I think that's a good point. Historically, there's been a lot of providers who have required or requested that patients see a therapist or a mental health provider before they access hormone therapy or surgery. More and more, our professional community is moving away from that and understanding that, like any other treatment, we should approach this as an informed consent and harm reduction approach. I think you made a good point here about, first, not requiring mental health intervention before providing hormones, understanding that hormones themselves may be effective in improving mental health for Marta. But two, if she has experienced mental health settings before, they may have been traumatic, they may have been anti-trans, and there's still a risk that when you refer someone to a provider, they may have an anti-trans experience. So some of the harm comes from our own system. We're almost at time, but yeah, we kind of like see a specific point of concern here with the suicidal history. If you recall from the 2015 survey of 28,000 trans folks, about 40% of them described having attempted suicide, which should be an alarming number. And if we think about why, understanding that transness itself is not a mental health pathology, it has everything to do with systems and anti-trans experiences and discrimination and stigma. And so while it does seem helpful to potentially name depression as a health concern for Marta and to make recommendations accordingly for therapy or antidepressants potentially, we may also ask her what she thinks would help and see if hormones is the answer, or one of the answers. All right, so I think we're at time, but I appreciate you all kind of thinking about this case and really taking the sort of like goals-oriented approach and the informed consent approach to heart with thinking about prescribing, understanding that like this is part of primary care. All of us can do this. If you think you're not seeing trans people, you're wrong. And I hope you feel encouraged to say yes when people ask you for gender-affirming care.
Just a few announcements before we break for lunch. Lunch is going to be on the 3rd floor. We're currently on the 4th floor. So if you take the escalators down, you'll see the lunch set up in the main hall. There has been an agenda change for this afternoon. After lunch, we were going to start with behavioral health, but there's been some travel snafus. So we're going to hear from Vib Gonzalez, who we're really excited is here from Cal and Lord. And they are going to talk about gender-affirming surgery and support services, and then we'll have behavioral health after that. I'll also include the Cal and Lord binding and tucking resources that were mentioned in the follow-up email that I'll send to everybody. That will also include all of the PowerPoints for today. And then just when you come back from lunch, there will be evaluations at the end of your tables. The evaluations are really important for us, and I'm just handing them out midday so that if you think of any feedback throughout the day, you can just go ahead and write them in the notes. We really value your feedback. This is our 2nd annual Gender Affirming Care PCI, and we're always trying to improve and make it more useful for folks. And so really any feedback you have, either for individual presenters or for the council as an organization, is really welcomed and helpful. So enjoy lunch. We'll see y'all back here in an hour.